All right, everybody, welcome. Thank you for coming to this month's edition of Insight's Grand Rounds video lecture series. We're happy to have Dr. Roy Torkator, who is one of the newest neurosurgeons at Insight Flint. He will be speaking on the topic of maximizing neurosurgical involvement in the management of brain and spine tumors. All right, Dr. Torkator, take it away for us.
Thank you. Can you hear me?
We can hear you.
Yeah, so thank you for the invitation to today's Grand Rounds. My topic is, as you discussed earlier, maximizing neurosurgical involvement in brain and spine tumors. So I'd like basically just give you guys a background of what I did for the last 10 years, trying to establish my neuro-oncology practice and trying to expand my tools, not only surgery, but also doing medical neuro-oncology, as well as expanding it to doing radiosurgery, not only for brain and spine, but also for spine cases, as well as also doing some intraventricular chemotherapy in some patients. So this is a case of, I did like 2 years ago, very young gentleman with right-sided weakness. The MRI here is demonstrating a ring-enhancing lesion with central areas of necrosis and some medial enhancing component here. So what is the pathology for this patient? We are not going to be 100% sure. We know the MRI is very sensitive, but it's not going to be specific as to the exact pathology. For this lesion, this can also be an abscess. The magic number is 25%. 25% of patients presenting with enhancing lesions may turn out to be low grade. In the same manner, 25% of non-enhancing lesions may turn out to be high-grade gliomas. So in that sense, very important to establish diagnosis by doing surgery. If possible, to basically resect everything so as to avoid sampling error with small sample size, and you can miss the high-grade component. And during my fellowship with Dr. Guha at Toronto Western, he would always tell on the OR that we should not just be a tissue provider, we should be able to engage our neuro-oncology counterpart in the management of patients. So structurally, we have an MRI possibly demonstrating a glioma. So you can do an MR spectroscopy, which is a metabolic imaging, examining the different metabolites in the brain. So you put a voxel here, and you run the MRI, and here you can see there's a reversal of the choline and an A ratio. So there's a reversal of that ratio, and that is pointing possibly towards a tumor process. You can also do MR perfusion, and you try to measure the blood volume, blood permeability in this area, the enhancing component, and you run the MRI. You have a control here, and you place the ROI here, and you can see there's an increased blood flow in this portion here, suggestive of a tumor process. So now you have more information. You have structural MRI demonstrating possible tumor, coupled with metabolic imaging showing increased choline, suggestive of tumor, and increased blood flow on perfusion, suggestive of an MRI, suggestive of a tumor process. But it's not going to be 100% sure. So the question we ask is there a survival benefit in the extent of resection for low and high-grade tumors? So in the study by Dr. Berger, Dr. Sanai at UCSF, they have found out that as low as 78% resection of the enhancing component of the tumor will have an impact on the OS of the patients. And more so with other studies before, Tumor et al. In Germany have shown increased PFS for patients who had resection using the fluorescence. The earlier study by Lacroix in 2001 actually demonstrated that a 98% resection of the enhancing tumor volume will have an impact on the outcome. And of course, resection versus biopsy is is also beneficial. And so with this, we can say that the extended resection has an impact on the outcome for high-grade tumors. For low-grade tumors, the group from Johns Hopkins actually look at their data, and they have shown that the extended resection for low-grade tumors had an impact on delaying the malignant degeneration of tumor, as well as increasing the OS for these patients. So looking at their data, they have shown that there is consistent, sustained increased survival data from 5 years up to 10 years for those who had underwent gross total resection of the tumor. So the extended resection confers a positive, significant impact on the OS for both low and high-grade tumors. Now, for the brain, it's always location. It's like real estate. So there's a potential for neurologic injury doing glioma surgery. So the question we ask is, why is it very important to avoid new post of deficit in glioma surgery or any brain tumor surgery? So again, the study by Dr. McGirt and Dr. Inosa at Johns Hopkins, they have shown that patients who develop new motor weakness or paralysis or language deficit post-surgery tend to do worse in terms of survival and quality of life compared to the same patients who had no new neurologic problems after surgery receiving the same treatment. And in the table here, we can see that there is a significant impact on the OS for patients who had no new post-op deficits after the surgery. So iatrogenic new post-op deficits is a negative prognostic indicator in glioma patients, lowering the OS and also impacting the quality of life for this group of patients. So the extended resection, as I've said earlier, is important, but it has to be tempered into avoiding new neurologic deficits for this type of patients. So the tumor is not the trophy. I've been around for quite some time. Even though you show the big chunk of tumor to the relatives after surgery, but patients develop paralysis or weakness or speech problems, they will not be too happy. So, and to add to the fact that glioma cannot be cured by surgery, so why would you want to have these problems being too aggressive, but you cannot cure it, and the same thing with cost deficit, it will lead to a negative outcome for the patient. But still, our job as neurosurgeons is very important because we have the first crack in making an impact on the survival of these patients. If we can do a very good job of achieving maximal safe resection, then we can help these patients have a better outcome and an opportunity for optimal treatment and outcome. So the brain tumor surgery, basically, as I said earlier, there are two critical clinical challenges. You have to be able to localize and define the extent of the tumor, at the same time identify the critical brain structures. So how do you accurately delocalize a tumor and define the extent of the tumor? So there's Dr. Perez is here. So one thing we can do is use neuronavigation. So it's like a GPS system that we use to basically localize the tumor. So here there's the Mayfield head fixation device with a reference array here, and we use that to register the patient's anatomy with the pre-op MRI images. So here This is the reference array, that's the camera there, this is the monitor. So once I use the pointer and put it on the scalp, I will know where am I in location to the tumor. So it's very, very helpful to localize the tumor, the borders of the tumor. You can plan your incision based on that. You can plan your bone opening. You can plan your trajectory. These are all very good before you start the surgery. Once you start doing surgery, remove the tumor, then you have issues with brain shift. So the brain will move because you remove the tumor, release the CSF, so therefore it's not going to be reliable at this point because the MRI that you have here are based on pre-op static images. So that is one drawback with the use of neuronavigation. So how do you identify eloquent areas in the brain? So one thing we can do is use the fMRI. So in the basal state, there's normal blood flow, or you have normal your baseline MRI signal. Once you are asked the patient to do something like move the hand or pout the lips, then you have increased metabolism, there's increased perfusion, and this will in turn result to increased MRI signal, which you can see on the fMRI. So just an example of a fMRI task-based motor mapping. Task-based, you ask the patient to do something, clenching, and it will show in the part of the brain that is responsible for that particular function. So this is the hand area, the foot area. So this we can see on the fMRI. You can also map the language area using fMRI. Yes, we do this task, and it will show the Broca's area as well as the vernix area over here, and you can sort of plan the surgery based on those locations. So for the patient earlier that I showed to you, this is the fMRI which was done. There is the hand area posterior to the tumor. Toe is over the feet is over here, so it's quite distant from the tumor. Most likely this is the Broca's area over here, and then the vernix area over here. So looks like the language areas are far from the tumor. The hand is close to the tumor posteriorly. So it's very important to look into the lesion to activation distance in relation to the tumor. So if the fMRI is very close to the tumor, if it's 5 millimeter or 0.5 cm close to the tumor, then there's a higher risk of developing post-op deficit in that area. So the farther away, the less chance of developing new neurologic deficit. So the magic number is 0.5. So if we can identify the cortical areas, we can also identify the structures, the tracts, which are also important in brain tumor surgery. So that we can do with DTI. We can do 3D anatomy with that. It will be dependent on the water diffusion and the anisotropy of the white matter tracts. So the big bundles we can visualize, crossing fibers cannot, and sometimes edema will affect the quality of their DTI. But it's very helpful. For that particular patient, we did a DTI, and we can see that the CST, or craniospinal tract, which controls motor function, is posterior to the tumor. And this is the brain lab monitor showing the tumor over here, and the CST is just abutting the posterior aspect of the tumor here. And you can do multimodal neuronavigation. You can incorporate the fMRI and DTI with navigation. And you can see here the tumor is over here, craniosspinal tract is medial to the tumor, and you have all this Fmri front and back, which is most like the vernix area, the Broca's area over here. So with that, you can plan the surgery as to where you're going to enter the tumor, probably over here, and try to be very careful as you're close to the vernix area over here. So for that particular patient, we did image-guided craniotomy and resected the tumor. This is pre-op. We do MRI within 48 hours post-op to make sure that we're not dealing with scar formation or post-surgical changes beyond 48 hours. So this is the pre-op, post-op MRI, maybe demonstrating a little bit of enhancement here. But you can always look at the T1 without contrast and T1 contrast study to check on this really enhancement or not. These are just probably a blood product over here. Maybe some enhancement posterior. So this turned out to be a glioblastoma. So now navigation will help you initially, but you do surgery, there's brain shift. So how do you deal with the issue of brain shift in glioma surgery? So we can do intraop ultrasound. So my mentor before would always castigate me for asking the radiologist to come inside, but I'd like them to be involved, so I asked the radiologist to help me with the intraop ultrasound. Intraop ultrasound is helpful because it can show you what's happening inside. It's not like a static image. These are real-time feedback. So you incorporate the navigation with intraop ultrasound. A patient that we did here, this is the ultrasound before we do the resection, the central area of necrosis, and then this after we resected, maybe some tumor here, I'm not sure. So it can help you more or less in defining the extent of resection or helping you where you are intraop. But I think the next best option, if we have it, is the intraop MRI, which can provide you with real-time imaging. You can visualize the brain shift, you can assess extent of resection, and you can monitor therapy. So this is when I was a fellow at Brigham's. We do the surgery at the Amigo Suite, advanced multimodal image-guided OR, where we have 3 ORs in one suite, the PET CT scan OR and the MRI room here. You can slide the MRI inside to do your intraop MRI. You can incorporate everything, your fMRI, DTI, and do all these things with the goal of achieving maximal safe resection. So you can also do surgery inside the MRI bore. This is when we're doing MR-guided laser therapy for radiation necrosis. And intraop MRI can basically help us in trying to determine or update us as to the location or the shape of the structures. This is before the craniotomy. After craniotomy, you can see that there's a shift of the fibers, and you can account for that intraop. And you can also monitor residual tumor. This is before the resection, and then attempted resection midway in the OR. Another MRI was done demonstrating residual tumor posterior here. Went back to the OR again and demonstrating gross total resection of the enhancing component. So I did this an unpublished data I did when I was a fellow. Basically, we collected data for low-grade tumors from this time period, and we did everything, CST, fMRI, and the same thing, we collected data for high-grade tumors. And the goal is to basically determine if there's an increase in the extent of resection using the intraop MRI. And we see that the extent of resection increased from 60 to 80% for low-grade tumors, and for high-grade tumors it's also increased from 84% to 94.5%. So with the use of intraocular MRI, we're able to increase the extent of resection, at the same time doing it safely with only a few patients having neurologic problems post-op, which are transient. And we compared our data with other centers, MD Anderson and in China, where they have more patients, and basically ours is comparable. The Brigham experience was comparable with other large centers doing intraocular MRI. But again, it's very expensive. You have to have a designated area. You have to train people to be in the intraocular MRI. The main issue, I think, with neurosurgeons is the increase OR time. You add at least 45 minutes to the OR time. So that's it for neurosurgical oncology. For neuro-oncology, I'd like to discuss certain aspects of medical neuro-oncology. I'm quite familiar with this. I was a fellow for 3.5 years and attending for 1.5 years at Henry Ford Hospital. So histopathology or molecular pathology will dictate treatment and prognosis of glioma patients. We all know that anaplastic oligos is better than astro or anaplastic astro over GBM. We have observed that grade 2 or 3 tumors have different behavior over time. Some will be indolent, some will progress in a short period of time if you observe them. And if you do surgery, they all look the same under the microscope. But if you give the same treatment regimen, they might, for example, you see 10 patients with astrocytoma, you give the same treatment. Maybe half will have good outcome, half will have different outcome. So why is that? They look the same under the microscope, but they have this different treatment outcome. It may be that phenotypically they're not the same genotypically. So this is the classic paper by Stoop demonstrating benefit of radiation with temozolomide plus 6 months of temozolomide for glioblastoma. The Kaplan-Meier curve demonstrating significant increase in the survival at 14.6 months compared to 12 months with those who only got radiation. So this is a patient of mine in 2013. This is a left deep medial temporal glioblastoma, which I was not able to resect totally. I did just a total resection. It's a younger patient. I think she's 36 at the time. So I gave her temozolomide. She was treated with temozolomide. I gave her adjuvant temozolomide during RT, and the MRI like a year after, demonstrating that the tumor has decreased significantly. I would probably call this a major partial response, and she was just followed after this, and then a year after, the tumor appears to be showing sustained response to treatment. Another patient with glioblastoma, this one's glioblastoma, had a nice resection of the right temporal. This is the right temporal cavity for the tumor resection. He was referred to me post-op by another neurosurgeon. I did RT temozolomide and then temozolomide, adjuvant temozolomide post-RT. This is the MRI after 2 cycles showing stable disease. But the MRI after the 4th cycle now showed progression. There's some enhancement here medially, and this is what we call distal progression, which is only present in 20% of patients with glioblastoma. Most of them will recur locally within 2 cm from the resection cavity. So, but in this case, he had a distal progression. So just to show you, same pathology, glioblastoma, same treatment. The top patient had shown good response sustained over the years. The other patient had shown early progression, not only locally but also distally. So for low-grade tumors, there's a study demonstrating that radiation with PCB is beneficial for low-grade tumors. There is a patient of mine, 2013, I think, with a right thalamic non-enhancing tumor, maybe some enhancement here. I did 2 target-guided biopsy. It was well at oligoastrocytoma. This is old. we don't use this anymore. So I treated her with RT temozolomide, and she had shown early progression after only 2 cycles. A patient with the same pathology, this was referred to me by the chairman, left temporal non-enhancing lesion, clearly seen on the FLAIR images. Only a biopsy was done. I treated the patient with RT temozolomide for 6 cycles. This is the MRI after a year, I think, showing a decrease in the area of the tumor, and then 2 years later, it showed sustained, almost complete response to treatment. And this is the left side, the reason for not being able to do complete resection. He's doing well up to now. I talked to him last year. He's an optometrist, and he's like maybe 9-10 years out. So there are molecular markers in gliomas. I will only limit myself to those that I have experienced: MGMT, 1p19q co-deletion, and IDH. So MGMT is the repair enzyme used by the tumors to repair the damage caused by the chemotherapy. Now, if you have methylation of MGMT, you're unable to repair the damage caused by the chemotherapy, and therefore you're going to be supposedly responding to the treatment. MGMT is a prognostic indicator for gliomas, and Hegi looked back at the Stoop patients, and she noted that patients with MGMT methylation had a significant difference in terms of survival compared to those with unmethylated tumors. So even those patients who are methylated and only got RT had better outcome compared to those unmethylated who got both RT and temozolomide. So 1p19q co-deletion is seen in oligodendroglioma. Nowadays, you have to be able to demonstrate 1p19q co-deletion to be able to make a diagnosis of oligo. So this co-deletion 1p19q is exclusive in oligos and is an indicator of good prognosis and also exquisite chemosensitivity, especially to alkylating agents. So basically, IDH mutation, once you have this mutation, you're unable to proceed with this reaction. And when you have that, you are now prone to genomic instability, and you're prone to responding to treatment. So this is just a table demonstrating what they did from TCGA. So they had 282 patients with diffuse low-grade tumors, grade 2 and grade 3. They tested for IDH1 mutation. So for those with positive mutation, they tested for 1p19q. Okay, and then for those with without mutation, they just basically this one. So this is just a wild type. This is IDH without mutation or wild type. What I want to point out here is that patients that are grade 2 or 3 gliomas, but IDH wild type, the behavior is not a low-grade tumor. It behaves like a glioblastoma. Okay, so the best tumor would be IDH mutation with 1p19q. IDH mutation with absent co-deletion is most likely an astrocytoma. So we go back to our cases earlier. We can probably say that this patient is a glioblastoma IDH mutant, and is probably a glioblastoma IDH wild type. And this is probably an oligoastrocytoma wild type, and this is probably oligoastrocytoma IDH mutant. So that will explain the different response to treatment for this patient, because IDH wild type will behave in a manner that is the same as high-grade tumors like glioblastoma. So this is a patient, a young guy I did 2 years ago, 7-year-old male with his left temporal tumor. He presented with some visual field defect. This is the MRI post-op. I'll just show you the pre-op preparation I did. This is the Fmri for the patient, demonstrating the speech area, the vernix over here, and the Broca's is over here. The craniosspinal tract or the motor fibers are medial to the tumor. So I tried to do my best here. Only able to remove portion of the tumor in the middle. There's a big vein over here, and it's close to the vernix area over here. So my goal is basically to preserve the function of this young guy. He's going to finishing high school and want to do engineering in college. So the pathology was astroblastoma, a very rare tumor. He was treated with RT temozolomide. This is the pre-RT, the post-RT temozolomide MRI. And then he was given adjuvant temozolomide. This is after 2 cycles, demonstrating some response in the treatment. And 2 cycles versus 4 cycles. You can see there's increase in the cystic component here. The tumor appears to be irregular. And this is cycle 4 versus cycle 6 of temozolomide. Cycle 4, tumor here. After cycle 6, it's getting smaller a little bit. So at this point in time, we decided to just stop the treatment and just observe the patient with interval MRI every 3 to 4 months. And this is the MRI comparing January 2020 and January 2021. You can see that there's a big difference in terms of the tumor size. He is off treatment for almost a year now. Okay. And this is looking at the MRI in May 2019 and May 2021, showing the big difference in terms of tumor size. So we were able to achieve reduction in tumor size despite not being able to do maximal surgery here. And the patient is doing well, able to finish high school, and is looking forward to enrolling in college. So I just want to show you this patient, 32-year-old male with headaches and word finding difficulty. This is a tumor in the left frontal area, resected nicely, and then had been treated with RT temozolomide and for a year, I think, over 6 months, and then he progressed after a year off treatment. So this is the MRI after treatment. This is the MRI when he progressed. So you have new enhancing portion here. He saw me at this point because he was off temozolomide for some time. I restarted temozolomide, but the MRI after 2 cycles showed progression compared to this one. And so at this point, I started patient on Avastin, bevacizumab, given IV every 21 days. You can see the MRI after 3 doses showing some decrease in enhancement, decrease in the edema, as well as mass effect. However, we have to stop the Avastin for some time because patient had to undergo surgery for cholelithiasis. And so once we stop that, there is rebound enhancement to be seen here after he was off Avastin for about 3 months. So this is a paper we published at Henry Ford before, demonstrating that patients can develop rebound progression after you stop temozolomide. So you have to stop it like slow manner. But in this case, we cannot do it because he needs to have surgery. So the other question is what to do once patient will progress on bevacizumab. And we published our paper at that time. We re-irradiated patients that progress on temozolomide and then maintain on that progress on Avastin and just maintain them on Avastin after the radiation. So the patient, even though he had not had any brain surgery. At that particular time, he had the cholecystectomy. You can see that there's really wound healing problems with Avastin. I think for neurosurgeons here, we need to be worried about the wound healing problems with Avastin as well as the risk of bleeding with Avastin. So the key number is 21 days or 4 weeks. So if you commit a patient to doing surgery, he has to be off Avastin for 4 weeks. So if patient had received Avastin and you want to do surgery, you have to wait at least 4 weeks from the last Avastin dose because you will encounter wound healing issues. So for the patient, what I did was to offer re-radiation to the area while waiting for the wound to heal, and also giving him chemotherapy in between. So this is the pre-RT MRI, and this is the post-re-radiation MRI demonstrating some response there. So he's going to resume Avastin, maybe plus minus CCNU subsequently. So we have tried to collect our data and try to publish this unpublished data. But what I just want to show to you is that we have similar regression-free survival and overall survival compared to the STU protocol. So next would be radiosurgery. So one of the tools we do as neurosurgeons is also to do surgery using radiation. So the concept of SRS has been there for a long time. So basically, if you do regular radiation, radiate the entire area. This is the tumor. If you do regular radiation, radiate the surrounding brain. If you do SRS, you just give localized radiation to the target with minimal or no RT to the normal surrounding area. Outpatient procedure, non-invasive, either use a frame-based, which we use, or also a frameless radiosurgery. We were the first to do radiosurgery in the Philippines back in 1998. I'm old. I was first-year resident at this time, so we wrote our experience on radiosurgery back in 1998. And the radiosurgery is very important for tumors that are 3 cm or less. 1 to 3 lesions or more can be treated. 2 deep, good radiosurgery target. 2 small, also. Eloquent areas in the motor strip, brainstem, carbonate sinus, thalamus. 2 ill to undergo surgery. 2 well, neurologically intact. Refuses surgery. Would not want any blood transfusion. If you have somebody who needs to go into systemic treatment because the extracranial disease is not controlled, as long as the lesions are consistently radiographically consistent with a clinical impression, especially if they're multiple. What I've learned over the years is that the radiation oncology physicians are comfortable working or doing SRS when the neurosurgeons are involved in the planning and the contouring of the lesions. And if you refer patients for radiosurgery, the patients are also comfortable if the neurosurgeons are there, are hands-on and present in the actual treatment. Just to show an example of a 72-year-old male lung cancer patient with a right thalamic metastasis. It's deep, it's an eloquent area. I did some cranial-spinal, I did some DTI to check where the CSTs are. It's splayed and not within the tumor, as is common in metastasis. So radiosurgery was done. This is the MRI post-SRS, I think 3 months out. You can see that the MET has responded quite nicely with a decrease in the tumor size here. Same thing here, 71-year-old male with esophageal cancer presenting with a pontine metastatic lesion, as well as a left frontal close to the Broca's area metastatic lesion. So these are eloquent areas in the brain. So we did radiosurgery, and this is the MRI 3 months after, showing complete response. Same thing here with the left frontal lesion. So the goal for radiosurgery is to achieve tumor control at the same time to preserve neurologic function or to prevent neurologic progression. So 16-year-old female with tribal mass underwent radiosurgery, nice response over here. So for receiver sonoma, I know we have neurosurgeons here. Sometimes patients would not want to do any open surgery, like this with this case. She had hearing impairment on the left. She had some hydrocephalus. I put a shunt, offered surgery, but she refused. So we did radiosurgery to target the area. And these are the MRIs over the years, showing a decrease in the tumor size, which was sustained over the years. So the patient did not have to undergo open surgery, no risk of facial damage or facial asymmetry, with typical for patients undergoing acoustic neuroma surgery. And I just want to show you the MRI recently for her. This is the pre-SRS MRI in 2013, and you can see the sustained response, a major partial response up to 2019. The patient I treated with SRS, a deep calcified meningioma here on the left in 2018, with the MRI in 2021. Maybe overall stable disease, but this patient developed complications with post-SRS swelling, and then it actually progressed with increased edema and midline shift. So I had to admit the patient, gave her high-dose steroids, and treated her with vitamin E and Trantal, which are options medically for radiation-induced changes. And luckily, she improved over time with improvement in the compression, the brain being more midline now at this point. So I was contemplating, should I increase the treatment or up the treatment to maybe using Avastin for radiation necrosis. We have our own experience before at Henry Ford Hospital. We use Avastin for radiation necrosis, and it showed response in terms of decrease in the flare and contrast enhancement, as well as clinical improvement. But for this patient, luckily she improved, and this is the MRI a few months after, showing no edema on the T2 sequences. So radiosurgery, as we discussed earlier, single dose radiation. Now, for patients with a larger tumor, 3 cm or more, it might not be safe to do a single dose radiosurgery. So hypofractionated radiosurgery can be an option for these patients. Tumors that are close to the brainstem, cranial nerves, also might not be safe to doing single dose radiosurgery because of the risk to these areas. So this is frameless, and we just basically collected our data for possible publication. The pandemic, made the residents have more time so they can collect the data. And so this is just example of patients treated with FSRT, a patient with petroclival meningioma on the left. This is before FSRT. This is after 4 months, showing a decrease in the tumor size, and then a year out, showing further improvement. A patient with pituitary adenoma abutting the optic chiasm here, refused surgery. We treated with FSRT for 3 to 5 fractions and stable MRI after a year. So we also use this FSRT for patients with brain metastasis. It's a patient I saw before the pandemic, a patient, I think he's 56-year-old male, presenting with headaches and seizures, demonstrating this right temporal multicystic lesion edema, He had a metastatic workup showing mediastinal mass. Biopsy was done, turned out to be non-small cell lung cancer. He also had one more lesion in the left parietal area. The decision was made to do FSRT because I want him to be able to proceed with systemic treatment for the lung cancer. So this was treated with 5 fractions, and the MRI showed nice response here in 3 months. So brain, that's for the brain. For the spine, we can also do spine radiosurgery. We know that spine meds is quite common. 100 patients a year in the U.S. Half of these patients will develop cord compression. The options for treatment: pain medication, steroids, surgery, and radiotherapy. Problems with conventional RT is that you radiate everything that the beam passes through. So the cord will receive a lot of dose. And also, it knocks out the bone marrow. So if patients want to proceed with chemotherapy, they cannot do so. Radiosurgery of the spine is ideal. You can spare the critical structure from radiation, and it's barely moving. So what you need is something that can immobilize the body. If you have the head frame or the mask for the spine SRS, you have the cradle device for the body. So that will conform to the body of the patient for proper positioning and immobilization. So we published our data. We were the first, I think, in Southeast Asia at this time to do SRS. And then recently, we have submitted this for possible publication, a follow-up study to the initial spine SRS paper. Just example of patients we treated: 60-year-old male with colorectal cancer, doctors post decompression surgery by orthopedic surgeons, and demonstrating epidural compression here, given spine SRS, and you can see the nice response here, spinal cord decompression at 2 months. 60-year-old male with colorectal cancer. This is the actual spine MRI, demonstrating a tumor over here, pushing on the cord anteriorly, given spine SRS. You can see now there's the tumor. The tumor is gone. You can see the cord and the CSF. 55-year-old physician with osteosarcoma, presenting with this epidural tumor ventrally, given spine SRS, and nice response after a month. 55-year-old male with prostate cancer, demonstrating tumor from side to side, given a spine SRS single dose, and the 6 months post-spine MRI showed nice decompression. This is one of the patients that I treated before I left for Brigham's in 2014. He was an 85-year-old prostate cancer patient, came in paraplegic. MRI showed this metastatic cord compression. We gave single dose SRS. This is the MRI in 2015 showing some response. And then he came back to see me in 2017, able to move the legs with almost complete response of the metastatic lesion here. So this is the same patient that I saw earlier, only on the cross-section. Tumor, it's all tumor, spinal cord, probably that one. Now this is the spinal cord, nicely decompressed after radiosurgery for the spine. The complication can be compression fracture. This patient we treated, he had renal cell cancer. We were trying to be more aggressive because he's radio-resistant, gave him 20 gray, and he suffered a compression fracture. And this is also the junctional area, T12L1, so it's probably not stable. So treatment for spinal cord compression from metastasis, we can give some steroids, and immediate relief, short duration, a long list of side effects. EBRT, the mainstay of treatment, either 10 doses or a single 8 gray. It can provide pain relief, but not rapid. It can provide neurologic improvement. It's non-invasive, but it has a protracted course. The durability of pain control is short. Rapidity of pain relief is longer, and you can have neurologic progression, and you knock down the bone marrow, which makes it difficult for the patient to undergo systemic treatment to control the primary problem. Surgery, we all know, is very important. Rapid improvement, tissue diagnosis. However, it's invasive. You have to do reconstruction, longer recovery time, and you also need radiotherapy. Vertebroplasty, pain relief, no spinal stability, improvement, no tumor control, risk of chemical leakage. But radiosurgery can provide rapid pain and neurologic relief, can decompress the spinal cord, it's non-invasive, it's convenient. It can be 1 dose or 3 or 5 doses, bone marrow sparing, so patient can proceed with systemic treatment immediately. But it cannot correct compression fracture or any instability. So this is the coding code that we can use for radiosurgery. Up here is the coding code for brain radiosurgery. This is the code, CPT code for spine radiosurgery. So if we can be involved with radiosurgery, then we can also charge our services, even with just application of the head frame for gamma knife radiosurgery. So one last thing I'd like to discuss is the leptomeningeal carcinomatosis, which is the spread of the tumor into the CSF. Nowadays, we can see patients living longer because they have good systemic control. And so we're going to see patients with more brain mets, more leptomeningeal spread, and we're also going to see patients presenting with complications from radiosurgery from our treatment. So treatment can be localized RT to the area, or you can do intraventricular chemotherapy with neurosurgery. Intrathecal chemotherapy via the Umaya or lumbar can be given, but there's more uniform drug concentration in Umaya reservoir. And this treatment can improve the PFS. It may not treat bulky disease. So this is the Umaya reservoir, catheter into the ventricle connected to the reservoir here. You need to insert this by the Cocker's point. You can either use freehand if it's a small ventricle like this, then you use navigation, either brain lab stylet or a varioguide like this. You always check the placement of the catheter post-op. You can either do a bottom inlet or side inlet. I would prefer a side inlet like this one, so that when you are in the ventricle, you don't have to move. With bottom inlet, you have to move to be able to attach this. So these are the things that you need. This is the methotrexate, a syringe, a 3-way stopcock, and a butterfly needle. So insert the butterfly needle into the reservoir, draw some CSF, and then instill the methotrexate slowly. So it can either be done patient sitting up or lying down. It's just an outpatient procedure that you can do. So just giving it slowly. And there seems to be no major issues when I was doing this before. So this is the first case I did, a 22-year-old female, a table tennis Olympian, who had acute leukemia presenting with this leptomeningeal carcinomatosis. And then she was treated with intraumaya methotrexate. You can see the response sustained in 2 months, even 8 months out. The enhancement that you see here have improved. And also she has some spine leptomeningeal also here and also here down, and that has shown response over time. So she did well. She had improvement in the diplopia and the lower extremity pain. This is a young lady, bank executive, who had bladder cancer, presenting with this right solitary brain lesion. I did surgery, a gross total resection, turned out to be bladder cancer metastasis. I did radiosurgery. I think I did fractionated SRS to the surgical bed, and follow-up MRI showed a nice response, but I may have dilated the ventricle here. And a month later, she developed symptoms, and the MRI showed leptomeningeal enhancement of the cranial nerve 7-8. I did intraocular methotrexate. This is the MRI after 3 months, showing some response there. She also had some nodule in the medulla, and then just showed some response. She also had right cavernous bulky deposit, also showed some response. And then this is a young gentleman with lung cancer presenting with this leptomeningeal deposits, the brainstem, midbrain, after 4 treatments, after 8 treatments. Same patient with this one also had deposits in the thoracic and cervical spine. This is the MRI before and after methotrexate, showing some decrease in the area. Same thing here. So this is basically just a case series of patients I did. We're trying to have this published. I have one CNS infection, mainly good response radiographically, 6, but I don't think it can be given alone. I think it should be combined with localized RT and then the intraocular methotrexate. So I think we can also try to expand our services at Insight by trying to put up a brain and spine tumor clinic. I think if you look at the landscape on brain tumor programs in Michigan, the top players are basically Henry Ford Hospital with the Hermelin Brain Tumor Center. My previous mentors are there, Dr. Mickelson and Dr. Rogers, and there are 2 other new guys. There are the big players. U of M have 3 neuro-oncologists, but there's only 1 senior. Wayne State, there's 1 neuro-oncologist. So these are the major areas covering the, I think, southwestern part of Michigan. Flint area, I look at the lineup of doctors in the area. They are medical oncologists mainly. There's no neuro-oncologists. And some I recognize because I used to dictate letters for patients in the area, and I recognize some of them. In the western part of the state, the one at Grand Rapids left, and she's in Florida, and they're looking for one. So I would, I'm dreaming that maybe we can put a clinic in our Flint campus. A lot of space there. Maybe Dr. Chuck can give us a small area, and we can start doing brain and spine tumor clinic. We have a neurosurgical oncologist on board. All of our neurosurgeons are competent to do brain surgery. I can function as both a neuro-oncologist. Maybe we can do some infusion in the area, and we can start seeing patients, and we can discuss at the Siena Tumor Board. We can do our own tumor database, and I can basically hook up with Henry Ford and be involved in clinical trials and get this thing going. I think that's my last slide.
Thank you, Dr. Torpator, for your presentation. Does anyone have any questions? If you do, please send it to me in the chat. Well, it doesn't look like we have any questions for the presentation. Thank you, everybody, for attending, and have a good evening.
Thank you.